Dr. Rajkumar, thank you so much for being with us here. And it was a wonderful session in which you and Dr. Costello really summarized almost the entirety of myeloma in 30 minutes for the community oncology team. So that was fantastic. I listened to it and, pearls of wisdom as always. Just for the viewers, again, reintroduction. I'm Sridevi. I work at Memorial Sloan Kettering in myeloma and CAR T-cell, and I'll have Dr. Rajkumar introduce himself.
Hi, Vincent Rajkumar. I work at Mayo.
Thank you. So, just going back on the initial point that we all touched in the discussion today, which is that about how to approach precursor diseases in plasma cell disorders, specifically the big discussion that's been going on at ASH 2024 is smoldering myeloma, all the trials that have been happening and how a lot of therapeutic agents have been tested in the smoldering myeloma setting. So a simple question to you, when you go back to the Mayo Clinic, hopefully after ASH, next week when you see a patient in clinic with smoldering myeloma, will you apply the results of the Aquila trial, and does that change your practice next week?
100%. 100%. You couldn't ask for more. We are not recommending treatment for MGUS. We are not recommending treatment for low-risk smoldering myeloma. But high-risk smoldering myeloma, as defined in Aquila or by the IMWG 2220, it will change practice. Because when you do a randomized controlled trial, you're asking, what are the primary endpoints? What are the secondary endpoints? And this is like a grand slam. Daratumumab given for a fixed duration of 3 years, prolonged time to active myeloma, time to CRAB, time to needing active therapy, as well as overall survival. So there's a significant improvement in survival. And beyond that, if you still don't want to change practice, then it's your inherent bias and not anything based on data. It did not adversely affect quality of life. It was safe. And we know DARA is safe because we use it in elderly patients who are not only getting DARA, but also indefinite LEN, DEX, and still they do well.
Correct.
So we're not talking about a toxic therapy that I'm going to give somebody and cause harm. The second thing is some people say, why don't we just treat it when the M spike goes up? But if you look at Aquila data, the M spike will go up in 90% of patients in the observation arm.
Right.
So you'll basically be giving triplet and quadruplet myeloma-like therapy for a lot more patients by using that approach.
Right.
Rather than simply saying we'll follow and when the M spike goes from 2 to 3, I will treat. That's going to happen in 90%. That happened in the control arm like that. You see progression as defined by myeloma progression criteria. So it's for those reasons, and this is the third randomized control trial that I've been involved with for smoldering. And it is the third randomized controlled trial that shows a benefit in preventing end organ damage, and the second to show a benefit in overall survival. Well imaged patients before to make sure no one with myeloma got in. And on an intent to treat benefit, there's a thing. So, so I believe this will change practice. It will be not only presented at ASH, but it will also come out in the New England Journal, and we'll figure out how the FDA reacts because it's gone to the FDA for submission, and it will go to the EMEA for submission, and then we'll take it from there.
So again, we probably have discussed it, but again, for our colleagues, would you wait for longer survival? And there's another question that's been coming up, like, will DARA exposure at the smoldering myeloma stage have any implications on re-challenging, so to speak, in quadruplets if ever they progress to active myeloma?
What do you mean by longer survival? There is longer survival.
There is longer survival, but there are echoes that they need to see longer overall survival before. Again, these are probably physicians who
are inherently biased, because we have done a study in which survival is superior.
Correct.
It does not need to be more superior. It is superior on an intent to treat basis. Patients live longer on the DARA arm.
Data coming from
a large randomized
who often really like in not just in myeloma but in other disease subtypes, they see like overall survival benefit 5 years out, 10 years out, and then they change practice.
No, they are changing practice oftentimes with progression-free survival in every solid tumor and every even newly diagnosed myeloma.
Agreed.
We don't have overall survival for DARA VRD, but we are willing to change practice. So this is more of like an inherent misunderstanding of what we are talking about for smoldering myeloma. Smoldering myeloma is a malignancy. High-risk smoldering myeloma. So we want to make sure that we don't harm patients. So if you're going to go against the results of a randomized trial, you should tell the patient that I may be putting you at more risk of not only adverse events, but also death. And if you're willing to accept that, fine, go for it. But the
And
patient
unless the
should know.
patient categorically says, I
No,
understand this and
exactly.
I do not want to be
Exactly.
treated,
Exactly.
monitor me closely, unless that we have enough evidence to proceed forward.
There is clear evidence of an improvement in all of the markers. The second question you ask is, will it affect future therapy? So how do you answer that? That is the experiment.
Correct.
You do a randomized controlled trial on an intent to treat basis, you see what happened. If survival is prolonged, that means that there was no detriment, because if that was the case, then survival will be worse. What else would you look for? And we also looked at PFS too.
Yeah.
That was also significantly longer. So we did all of the things that we are supposed to do, and there are no more trials coming.
Yeah.
So you either have to believe this or believe your bias.
Yeah, I think it's a trickle down effect, right? I think the practice has to change, and then people need to hear this more, need to like distill the message down clearer as we are trying to do right now, and then change
It's a
practice.
fundamental misunderstanding of what is smoldering myeloma.
It's not a true precursor or non-malignant or benign. There's actually malignant cells that are
Malignant cells, and myeloma is the only disease where we are saying, just because 50 years ago somebody said you need end organ damage, otherwise I won't call it myeloma.
Yeah.
We cling to that. But no, we don't do that for any other cancer.
Oh, no,
If
for
you said,
early-stage breast cancer,
yeah, exactly.
you-
If
you'd
without
like to be
symptoms, I will not
radiation
do
open.
it. That's not the way.
Absolutely.
It's really hard to show survival benefit for a disease where even in newly diagnosed myeloma, it's hard to show survival benefit. And so one has to really be honest to the evidence as it is. We have the odds that DARA will cause harm are extremely low.
Yeah. Sounds great. Now, in myeloma, we have the advent of a lot of immunotherapeutics and other classes of medication. So, what would you think are some of the therapeutics out there that we have in the armamentarium for myeloma that it would be good to have a tertiary care center really co-manage in the initial phase? For example, I'm talking about CAR Ts bispecifics, but can you think of other drugs that would be helpful to have a tertiary center opine and help along and then transition back to the community?
So, thankfully, other than CAR T bispecifics and to an extent belantamab, most of this other things can be done in the community that we are currently using for myeloma. That's one. Number two is we are in a good space right now. 80 to 90% of patients with newly diagnosed myeloma today will not need to think of even a second line regimen for 4 years.
Yeah.
And who knows what happens in 4 years. And then even if they need second line, as I mentioned here, I would rather use some of the usual tried and tested regimens. And that you're talking about another couple of years. And then at that point, I hope by then we learned how to use bispecifics and CAR T to the point where we can really decide how long should somebody be in the academic setting and how long. Now they are talking both for CAR T and bispecifics, at least moving from the academic center to the community as quickly as possible. If you talk about CAR T and you say that it can only be done in an academic center, then only about 2 or 3 patients out of 10 who need CAR T will ever get it.
Oh, absolutely.
So we have to find a way to how to make it a reality, which means that either we need safer CAR Ts, and some data now at the ASH meeting about anito-cel. Maybe, I don't know whether it's safer because of the product or because of the way they selected patients or the way they gave the prophylaxis. All of that can be worked out to identify a group of patients who can be possibly managed outpatient CAR T in a community setting. I'm talking a few years from now. Versus some patients have to be here.
And a lot of centers, including your center and mine, we are already doing CAR Ts outpatient, and we are getting quite comfortable with it. And we are expanding the radius of how long they can stay away. At least at MSK, we are doing, our radius is now almost 90 minutes out of. Again, you have to account for New York City traffic, which is why 90 minutes. But a few centers are already doing. So again, limiting that selection bias and that access bias that patients have. And, a patient coming in from Philadelphia or New Jersey, not really being in that 90-minute radius of Manhattan shouldn't be precluded from CAR T just because of their geographic location. Yeah.
We need a lot of training probably for community oncologists on patient selection, the actual scheme of how we're going to do it. But I think it will expand eventually
Yeah.
Unless we find some treatment that's really dramatically better than this, that we can
hope.
we can hope.
That's the hope. That would be the goal. A final question to round up would be dexamethasone, which again has been a backbone for decades in multiple myeloma, and we are now finding that maybe the dosing of dexamethasone need not be the canonical dosing that we are all used to. So, what is your take on that, and what is your advice to community oncologists, like how to go about dexamethasone dosing? Initially, when would you think about de-escalating? Who would you start at the lower dose itself? And how do you go about it?
Yeah, it's really funny that you said the canonical dosing, because when I started, the canonical dosing was 40 milligrams, 4 days on, 4 days off, 4 days on, 4 days off, 4 days on, 4 days off, and patients would get significant proximal myopathy and things like that. And it was really a patient-inspired randomized trial that showed us you can get away with 40 once a week. And then we found out that patients over the age of 70, you go 20 once a week. Now, I think the thinking is more to do with the duration. That can we stop it at 6 months, or can we stop it at a year and not give prolonged steroids? Can we drop the dose quickly after a patient has a response, so that you start with 40 once a week, but in a month or two try to go down? I do that already because I feel like while steroids are an important component of myeloma therapy, because steroids are toxic to plasma cells, we are using them because they are a chemotherapy drug for. Exactly. So they are useful. I don't want to discard them. It's a single agent response rate of 45% in newly diagnosed disease, which is quite high. And so we don't want to say no to that, but learn to use it cleverly so that you can use it when needed, stop it when it's not needed. So I feel that that way the field is going to go. There's an abstract here which looked at RD, which is a good regimen, versus DARA-R, and showed that DARA-R was quite good, and you can spare the steroids after the first cycle. Future would be like, can we do the same with DARA-R versus DARA-RD, and really head to head, or even do like some real world studies to compare the two if you're not able to do randomized trials. And maybe we'll find that as long as you give dexamethasone for the first 2 or 3 cycles, then after that you can back off, and DARA-R is just good enough as DARA-RD.
Oh yeah, and patients also come asking for exactly the same thing, right? They understand in the initial cycles it's important for tumor reduction, cytoreduction, and after that it's always a discussion, and and I have pharmacists asking me, "Are you sure you want to drop the dose?" And I always reply back, "Yes." So those are just some summaries of what we discussed. I'm looking forward to seeing the full discussion in full with the Oncology Brothers. Thank you so much for being here,
Thank you so much for
and
having me.
happy ashing.
Okay.